So we're going to talk a little bit about sleep. First, your education for the day from our liberal arts side. So many people use the quote, "to sleep perchance to dream," as though it's about sleep. It's not. It's actually from Hamlet when he's contemplating suicide. And that was my last talk, so we're going to move on from that. Simon probably already knew that, given his background. But
Nice tying them in together.
Tying them together.
I like it.
So, oops, it's going myself. Okay, so I wanted to talk a little bit about normal sleep. Normal sleep has what we believe are 5 stages. Sometimes you'll hear people say 4, but then what they mean is 4 plus REM. So you'll hear it listed that way sometimes. And we all go through this, and of course it can get disrupted, which is what we're going to talk about today briefly. But basically, initially when you start to fall asleep, you're obviously in a light sleep phase. When they look at thousands of humans, human brains, and they run EEGs and so forth, that seems to be about 4 to 5% of the sleep cycle. Then we have a stage 2 sleep cycle. And there are physiological changes taking place at this point in time. So it mentions here the slight decrease in body temperature and so forth. You're going to get into a slowed breathing pattern and heart rate. And that's going to be a lot of your sleep actually time. That's about half of your sleep time. Then we have some deep sleep. And you have, when they look at EEGs, you'll see most commonly alpha waves, delta waves, and so forth. So if right now, if all of you closed your eyes while I had an EEG on you, we would see alpha waves immediately start to pop up. When you're getting into this deep sleep cycle, you start to see more of these slower, what they call delta waves. And then finally, we move into this very deep sleep. It's rhythmic breathing, not very much muscle activity, and you've got a lot of delta waves. And that is felt to be one of the more restorative parts of the sleep cycle. And then you've got this rapid eye movement. So this is where if you're actually watching somebody sleep, you can see their eyes actually moving back and forth, and they're actually going through this type of dreaming state. And the idea is that the muscles relax, the heart rate increases, and then you've got this more rapid breathing. And of course, you might, if you're in a dream, believe you're running. That could increase because you will have some autonomic effects. The brain is supposed to shut off the control of the muscles so that when you're dreaming about running, you're not actually running. Although we all know that there are disruptions in the sleep cycle can lead to things like sleepwalking, and as we talk about some of our medications, even fears of sleep driving. So that's one of the things we're a little bit worried about when we treat sleep, and every sleep treatment disrupts the sleep cycle somewhat. So I've kind of gone through this. Just gives you a quickie. I gave you that other overview. This gives you the basics of the sleep cycle, and the other thing is it's not a sequence necessarily. So we're starting with non-REM, and it goes through the phases I just described to you, not exactly in order. And a REM, again, is felt to be very important and can last up to an hour, depending on how deep you're into that part of the sleep cycle. So this just gives you a pictorial of that, of how it kind of does this loop between non-REM and REM sleep. We all go through it. For time's sake, so I can get to the medication part, I'll go pretty quickly here. And it's going faster than I want to even. But so anyway, so again, we also know that the sleep cycle changes with age, and you hear about that. You often hear about older individuals seem to get up earlier and go to bed earlier, and things that just kind of change. And you'll notice that, in fact, as people get much older, they have less total sleep time. And this is, again, a lot of normals being studied, and it's not that they're sleeping 5.8 hours and therefore they're always exhausted. If at age 20 they were getting 5.8 hours, they probably would have been feeling pretty tired and fatigued during the day. But at 80 years old, they actually are not having that problem. So we're getting an update on the slideshow here. So
It won't even let me change it.
that's okay. We're good.
Okay. Sorry,
We'll make it work.
better for you.
No problem. We're fine. So, okay, and then you can also see that the times I gave you as an overview of the sleep cycle do also vary with age. So there's a little bit of difference there in terms of time of sleep while in bed. You'll see at age 80, the time you're actually asleep is less than it is when you're 20. And any of you who have teenagers know that they tend, especially in puberty, to sleep longer and later. If you allow them to sleep in on the weekends, they might even sleep till 3 in the afternoon, depending on whether there's anybody waking them up nowadays with text messages and things of that nature. All right, that doesn't do it all. Yay, it's fixed, sort of. Okay. So DSM-5, they've done some reclassification and renaming within the sleep disorders. And so now they're calling it sleep-wake disorders. And this is just a big, I'm not going to do all these today, obviously. That would take several hours. But just to give you a sense of this, of how they've categorized them, these are all the big categories. And you can see there can, in fact, be a non-REM sleep arousal disorder. There's nightmare disorders. There can be a REM behavior disorder, such as sleepwalking. So there's those kind of problems that can actually occur with this. So here's the DSM-5 criteria. And I just realized I pulled this slide, and the slide, but just so you know, this slide is wrong. Anybody see what's wrong about it in the title? So what's wrong is that there is no V. They switched it to DSM-5 because the V, the Roman numerals, don't translate to other countries. It's something that's only sustained in the U.S., so it's actually supposed to be the DSM actual number 5. So when I pulled the slide, apparently they didn't know that. So just one little aside for you. It should actually be the number 5, not a Roman numeral. Anyway, so you'll see, just like all the other disorders in the DSM, we've got a category list here of things that you have to meet at least 3 nights a week for at least 3 months. So this is not, oh, I'm going through a rough stretch at work, it's stressful, and I'm not sleeping as well. That's all of us, right? We've all had that happen, and you've had that happen for final exam week, whether it was high school, college, what have you. We all go through periods of time we're going to have trouble either falling asleep, staying asleep, or waking up earlier than you wanted to. Those are the 3 big categories when we look at sleep disturbances. And of course, the real one is always that we want to see something where it actually causes clinically significant distress or impairment. And pretty much all of the categories in the DSM-5 have gone to that piece. We're trying not to overdiagnose illness in general, and including with these disorders such as insomnia disorder. So insomnia is now insomnia disorder. Again, therefore, it has to interfere and so forth. And again, it was changed to 3 months. So it's a longer time as we look at this. Part of that's because the belief is there's an overuse of sleep medications in individuals who are trying not to have that happen. So the other piece, of course, is this objective daytime sleepiness. So if anyone's ever gone in for a sleep discussion or sleep study with an electrophysiologist, they're going to ask you those questions. If you end up saying, well, no, I don't think I'm sleeping well, but then you also are never taking naps and you're not really having trouble, you're not going to fall asleep, they'll ask you questions like, well, you ever fall asleep sitting in a waiting room waiting for the doctor? If that's a yes, that's an indicator, because most of us, as boring as that is, don't fall asleep sitting in the waiting room usually. Now, obviously it happens. And if you think about older individuals in your lives, and in fact for elderly, they often you'll catch them napping, right? That's much more common because they're having a different sleep pattern now than they had when they were 20 and so forth. PSG is polysomnographic evidence, so that means they've actually got you hooked up to EEGs and so forth, just so you know what that PSG stands for there. The treatments for insomnia, first and foremost, is sleep hygiene, which is a fancy word for creating the right environment and the right sleep pattern, pre-sleep pattern, so that your brain gets all the cues that it should be getting to go to sleep. So those of you with younger kids, you may try the milk or milk and cookies, and it has nothing to do with the milk and cookies. People try to argue it's tryptophan or something. That really has nothing to do with it. It's really that sequence. So now your kids know that when you get to the point of milk and cookies, that sleep is coming soon. And they know that both consciously and unconsciously, their brain is like, okay, I'm headed towards sleep. At the same time, other physiological things are taking place, such as natural melatonin being released in the brain, which occurs especially when we get away from light, in particular blue light. So you've heard a lot about blue light. They sell glasses now that block the blue light. Your iPads and iPhones have and probably the Android phones as well, have a way to turn off, filter out a lot of the blue light, so that if you feel so inclined to be looking at phones at 10 o'clock at night, at least it's causing less of a dampening of your melatonin response, which you need to fall asleep. And then, of course, drugs, and we'll get into those in a moment here. So psychiatric disorders and sleep, just to give you a sense of this, about 6 in 10 Americans report having insomnia and sleep problems at least a few nights a week. Another reason for us to say, let's not call that a disorder, because it's the actually majority of us are going to have some of that. As annoying as it is, we're not going to call it a disorder, but we do have to call it a disorder when we get into that 3-month time frame and it's starting to interfere with our lives. And I'm sure prescribers would probably consider treating it if it's less than 3 months, but you really are having trouble in your life because of it. So it's going to get into that usual clinical judgment that we have to all deal with. Mood disorders do have a change. You've heard of atypical depression, which I'll just focus on for a moment, where people, instead of having decreased sleep, even though they may feel tired, they don't sleep well, and they tend to have a lower appetite. In atypical depression, they actually have increased sleep. They literally sleep more. They're not just laying in bed awake, not sleeping. They're actually sleeping, and they also eat more. And in fact, we tend to treat those individuals best with MAO inhibitors. That's the one time you'll see prescribers use an MAO inhibitor. Okay, so anxiety disorders also very commonly related to insomnia, right? If people are laying there, my private practice patients will tell me how much they lay and ruminate. And they just can't shut their brain off is what they'll tell me. And it's not because they're hypomanic. It's not because they're manic. It's that they have a lot going on in their lives that's stressing them. When we talk about, again, starting with sleep hygiene, how to deal with that. It's also very common in depressive disorders. And of course, our first treatment, just to highlight that, is to treat the underlying disorder, right? We're not just going to slam them with sleep. And I, quite frankly, have at times with patients that are just adamant they have to have this drug, that drug, use the Michael Jackson example and say, well, look, he couldn't sleep and he got to a point where he needed propofol with an anesthesiologist to put him to sleep. We don't want to end up there, and they'll laugh and then realize they're kind of asking for that though. And I'm like, we're not going to go there. That's not the solution. You're having, my patients almost all have pain. We're not going to medicate you so much that your pain goes away so you sleep. You need that to be treated. Your pain disorder has to be treated and so forth. Okay. Treatments. So I mentioned sleep hygiene. This is really the hallmark. We should all be doing a better job of explaining to this. And so here, what that means. Number one, a regular sleep cycle. And they really do recommend that this is true on weekends. And many of us, myself included, screw that up. I'll tend to stay up later and then try to sleep later if I'm able to sleep later, or if other responsibilities or even fun ones don't creep into that. But we really should try to have a pretty standard sleep cycle. Exercise does, we're seeing research now, it helps depression. It also helps our sleep cycle. But you can't do it within a few hours of bedtime, or at least most people can't. It will actually cause too many other factors to stimulate your brain, at which point, of course, you're not going to sleep very well. You want a relaxing evening routine, again, sort of the opposite of exercising right before bed. The bedroom is really supposed to be for sleep and sex. It really isn't to read a book. It really isn't to watch TV. It isn't to sit and work on your final half an hour of studying for your test. And I say all those things because those are all things that we've all done, myself included. You really are supposed to make the bedroom. And why is that? Because it's a cue, just like the milk and cookies. The cue is when I get in bed, I'm going to get in bed primarily to go to sleep, maybe sex and then sleep. Sex is shown to improve sleep, actually, so that's another reason for that. But those are the two things you should be doing in your bedroom, and particularly in the bed. Obviously, dorm rooms often have the desk in the bedroom because it's one little tiny room. So you kind of, at least the bed itself ought to be designed just for that. Caffeine is a huge problem in our society, as I sit here with my coffee in front of me. And obviously, if I were to drink that, many people who drink prior to 5 o'clock, if they're regular caffeine drinkers, do okay with this. But if you start drinking it much after 5, even if you don't think it's interfering with your sleep, it probably is. There's a lot of evidence on that now. I mentioned the blue light already. Alcohol. Many people will have a glass of wine or something with their dinner. To go on and continue that and have that later also screws up your sleep. You may think it's relaxing you, just like a benzodiazepine, because it's the same GABA effect basically in the brain, but it's not going to help your sleep cycle. The meal piece, disruptive noises, that's not a brainer there. And then, of course, you don't want to be in bed thinking, gee, why am I not sleeping, and constantly looking at the clock. There's also good evidence to turn the clock away. Many people just hate that. Oh, no, I need to see the clock. Well, no, you don't. The alarm will go off when the alarm goes off. And if you keep looking at the clock and it's 30 more minutes, you're only creating a new rumination about why you're not sleeping, right? So that's another problem. So I've already gone through most of this. So one of the treatments is to emphasize the piece about the bedroom. All right, so this is the stimulus control therapy. And they literally, in this case, because now you're being treated for the insomnia disorder, tell you to get out of the room. If you're laying there awake in 15 minutes and all you're doing is laying there trying to sleep, you're not in there reading books and all that, then get out of the room, because you want that room to be associated always with actual sleep. So that's another big one. And you add this whole stimulus control to good sleep hygiene. Again, same sequence every night before you're headed towards bed, whatever that sequence is very helpful. Don't take naps during the day if you can avoid that, to keep your cycle on track. You want to be tired when you go to bed, right? The goal is not to try to do that. One of my sons tends to sleep late on the weekends, and then it's not surprising that he can't go to bed at a decent hour that night. Anyway, we try to have that conversation pretty regularly, especially in the summer. So that's a problem, right? Because you're not going to be tired if you've only been up for 12 hours before you're trying to go back to bed because you slept so late. So that's an issue. And then we get into medications and then some non-medication things. So the non-medication ones I'll jump to first. Herbals, valerian root tea, kind of like a medicine. Many people swear by this. I saw one study that showed this does beat placebo. Aromatherapy, lavender in particular. I went to a conference a couple of years ago, and they actually provided a little jar of lavender aroma oil that they recommended that you put like on your cheeks or something, so you would be inhaling this while you were falling asleep. I'm not sure if it works or not. I didn't try it actually, but some people actually do swear by that. Progressive muscular relaxation, just as one example of a relaxation technique. I'll mention it I choose the product because I can tell you about it real fast. Basically what they do is you lay there, you generally close your eyes, you squeeze your toes as tight as you can and hold it for a few seconds, then you release it. And then you do the same thing, flex or extend your ankles, hold it tight, then release. And what you're supposed to be doing is paying attention at that point to the warmth of the blood coming back into your muscles and so forth, because now you've released that. And you move that, you keep going up your body. Many people find once they're practiced at this, they don't get to their head and they're already asleep. So that actually can work very well as just another way. So you're no longer focusing on whatever you're ruminating about or whatever might be coming up the next day. You're now focused very much internally on your body and those sensations. So that's one quick way to at least try something. So the soft noise machines, interestingly, because those have become so dominant, and in fact, most of our phones probably have an app that lets you do this, there's really good evidence that white noise, pink noise, brown noise, that are pink and brown are versions of white noise, or very soft music, not heavy beat music where you feel like you want to dance in bed. You need something that's going to kind of calm your brain, and that actually also works. Many people try antihistamines, and in fact, every medicine over the counter that says anything with SOM on it is pretty much Benadryl. So you're going to see diphenhydramine, Benadryl in a lot of products, and many patients don't know that, so it's often important to point that out, that they're not taking their NyQuil PM and Benadryl, because they may actually be overdosing themselves on Benadryl. Some people, by the way, get a paradoxical reaction to diphenhydramine, and actually it wakes them up, speeds them up, so you have to be aware of that. Hydroxyzine, which of late has been hard to get. There's some kind of a back order issue with that I've had with my patients, because I tend to use this one fairly regularly. I can play it up because it's a prescription medicine as opposed to Benadryl that they've already tried, to avoid jumping to one of the other sleep meds. And it often works. So Atarax or Visceral are different versions of hydroxyzine. Visceral is the one that's been harder to get of late, so I've been using the Atarax, which does work for people. Melatonin supplementation also can help. The negative of melatonin is it's hard to know whether you're getting the right dose of melatonin or what's actually in the bottle, because it's not controlled by FDA. So there are some companies that claim they're getting official reviews and all that sort of thing, so that those are probably the better ones to choose, so that at least there's a better chance. And maybe, in fact, the pharmacy will have some evidence of that, and the pharmacist can advise you on, hey, yeah, choose this brand because we've seen evidence of this one has, if you want 2 milligrams, it's got 2 milligrams. In it, that kind of thing. Magnesium is another one. People that have magnesium deficiencies tend to wake up more throughout the night. And so that's one to attempt. And in fact, you can get a blood level on that if you're really having trouble with sleep. And the sleep specialist will automatically do that if you come in complaining about it. Calcium also helps us use the tryptophan that I alluded to before, which is there is some of that in milk. There is some in turkey. So you hear that discussed every Thanksgiving. People bring up the tryptophan and why is the whole family asleep after the big meal. Most of that's because you just had a big meal. And you're probably trying to avoid too much idle chatter with your family. So you're taking naps, right? So anyway, so tryptophan works in the pathway for melatonin. And it does also, calcium is very much involved in our REM sleep cycle. All right. So these are the medications that are out there now. We've got originally people used benzodiazepines, Restoril, Rest, not surprisingly, Halcyon are two that have been around for many decades now. And I've used both with patients. I try to avoid them, but I have used them. I actually like Restoril. I think it works well, but it's, again, not something you want them to become taking every night. This is where they're struggling for a period of time in their life. I've got a patient who lost his father. He's been struggling more, so he's doing that and not taking it every night. And I know that because when I saw him after 1 month, he said, "Oh, I don't need a refill. I'm really trying to use it sparingly." So I felt good about that. That's a pretty good indicator. The ones that started coming out, I think Ambien came out in 1994 while I was a resident, which is the reason I remember that. And so these are the ones. Zolpidem is Ambien, Zopiclone is Lunesta, Zaleplon is a Sonata. All very similar, working again on the GABA-A receptor. And the negative with Ambien that I noticed actually in the first patient I ever gave it to is it tends to have more of an effect on sleepwalking. Especially I've learned before I give any of these to a patient, I now ask if they sleptwalked as a child or as an adolescent. If they say yes, I'm even more reluctant to give them these. My patient, who was a well-to-do woman married to an accountant living in a very nice neighborhood in Baltimore, was very embarrassed when she came in and told me that her neighbor had caught her in her nightgown watering her lawn at 3 a.m, sleepwalking. And I did then learn to ask her, and she said, "Oh, sure, yeah, I did sleepwalk as a kid." So this was just on the market. When these came out, they were marketed as, "Oh, they're not like the benzos, they'll be perfectly safe." And they weren't scheduled. And then as we learned more and more about them, they became scheduled. So they are actually controlled substances. And then we have the antidepressants, some of which, the older ones in particular, the tricyclics like amitriptyline, will indeed make you tired. Doxepin has very strong antihistamine effects. And so it's also out there as a sleep medicine for prescription at times. I like trazodone actually for some patients, again, sparingly and not nightly. Deserel is the brand of that one, also works well. And I've seen one good study, maybe two, on people with post-traumatic stress disorder. If they get an SSRI and then they also get a little bit of trazodone for sleep, that seems to be a good combination, and you don't need to give them 6 meds, which is what often happens with that diagnosis. Mirtazapine, which is Remeron, works even differently than the other antidepressants and is very sedating, but it's an unusual medication because at the starting dose of 15 milligrams, it tends to make almost anybody fall asleep. As you go higher on the dose, it actually has less sleep effect. So you have to just be aware of that. I explained that to the patient, saying, look, if your depression is causing your sleep problem, we'll start you at 15. It will help you sleep. If it doesn't then work after a couple of months for depression, we'll raise it to 30. And ideally, if your depression's getting better, you'll still sleep well, but you won't be knocked out. But I had a patient not trust me on this, and she broke a 15 milligram in half and slept for 20 hours. So it read 7.5 milligrams. It was very sedating. But she at least learned to trust me after that, as far as I can tell. Antipsychotics, again, low potency ones. Thorazine was the original one. It's a low potency. And now quetiapine often does get used, particularly in individuals who we don't want to give a controlled substance to and nothing else has worked. you may consider Seroquel because you don't want to give them something that will trigger that dopamine release or dopamine surge that will get them back into their addictive brain problems. So the newest kids on the block, Ramelteon, which is called Rosarem, basically it mimics melatonin in the brain and activates those receptors. And it's pretty much one dose, 8 milligrams. Almost everybody gets 8 milligrams. I saw one study where they did 16. But in theory, every mammal brain is fully saturated as though you had your full dose of melatonin if you take 8 milligrams of Rosarem. So you shouldn't have to go above that. It's not cheap, so not every insurance covers it now. And then the newest is Surovexant, which is Belsomra. I like this one just because of the unique action. I've actually not been able to use it in many patients because it's expensive, and the companies don't cover it. I've had a few use it, though. This one actually blocks the chemicals that keep us awake. So as opposed to trying to help the system that puts us asleep, it blocks the system in the reticular activating system of the brain that keeps us awake, and it works. They have scheduled this one. So Rosarem is not a controlled substance. Belsomra is. Because of that strong effect. I don't think it has much of a dopamine effect, but it is scheduled now. They all carry this label for short-term use. It's not supposed to be long-term use. You're not supposed to take them with alcohol. We can see why. A lot of them are benzodiazepine-like, so you might cause problems with respiratory issues, and then they literally could die from an overdose of alcohol plus those drugs. I already mentioned the Ambien. Oh, there were other problems that came up with the Ambien. So part of the Ambien issue in the beginning was people complained it wore off too early. So they would sleep great for 4 hours and then wake up and had slept enough, they couldn't go back to sleep. So they created Ambien controlled release, which is kind of weird dosages, 6.25 milligrams and 12.5. The 12.5 milligram dosage in women in particular, and this so far they've not extended this to men, seems to have a hangover effect, even if they don't feel it, that decreases their reflexes. And they discovered this because there were women having car accidents in the morning, and they did enough studies. So now I don't think it's forbidden, but you're basically not supposed to give it to that high dose to females. And in fact, I rarely had anybody on that dose, but I stopped it on the patients except for one who had been taking it before I even saw her. This is what the quiz is on today, so just memorize that. You'll get the slide set, which is why I put this in there. You can look at that at your leisure. And then I just want to mention one more, Prazosin mini press. So very, very different medication. It's an alpha-1 adrenergic antagonist, and there is some data, although a more recent study says no, that's why I say not all, saying that prazosin works for nightmares related to like PTSD. I've actually had great success in about 5 or 6 patients now in the recent couple of years, maybe 3 years, using prazosin 1, or I think the highest I've gone is 2 milligrams. So you don't need much. It seems to have no side effects, and again, in the handful or so of patients I've used it with, and they love it. They've all told me their nightmares got better. And now their nightmares were because of the nature of the injury, what caused their injury at work. They did have a traumatic event that led ultimately down this sad path on workers' comp. But again, it's not all studies showing this, and it's therefore not FDA approved for this purpose. Alcohol I only mention because lots of people think this is what helps them sleep, and it isn't. So just so you're aware of that, if people ask that or bring it up, it is not something that improves overall sleep quality. And then here's some references, some of which refer to that chart that was on there. And hopefully